Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. So today is Top 10 Tuesday because we're at the last Tuesday of May, and I have a lot of questions that came in from my Coding Corner members, executive members, and for those of you that are wondering what that is, we have a membership Q&A where you can ask questions through email, and it also comes with some discounts, some auditing options, some free webinars, and Ask Me Anything quarterly meeting. Just depends on which plan you pick. It's per year, so take a look at terryfletcher.net if you're interested. But I like to also bring some of these questions to you, and I'm going to start also putting them on my blog so that you can read through them. It may be something that you're interested in later on. I have a mixed bag because we are multi-specialties, so something to definitely consider. But here's question number one. Let's get right to it. It says, Terry, my physician wants to report the add-on code G2211 to Cigna for a pediatric patient, but the plan does not pay for this Medicare add-on. The doctor thinks if he bills it, eventually the plan will pay. What's your take on it? So everyone knows Medicare has definitive rules on billing for non-covered services. They have, in those rules, certain corresponding modifiers that also reflect if it is statutorily not covered. I know sometimes you want to get it so, the denial so you can send it to your secondary insurance. But we're talking about commercial plans and the standards for medical billing. So a physician can technically bill for whatever they want except for bundled services because that's double dipping. But let me be clear about this, and I have said this before, but you need to hear it. If the service is plan excluded, and you know it because either you've received denials that has told you that through an EOB or because you've read it in the policy that it will not be paid, then the plan will either likely transfer it to the patient responsibility, or I've also seen that these types of claims have been subject to the False Claim Act when the insurance plan has in writing said that it's not covered. You signed that contract, remember? So then the billing it is going against the plan, and you could be sanctioned for bad faith. So only T-codes, new technology may be reported, but then again, what you're dealing with T-codes, because there's no fee schedule for those, is that the patient may have an out-of-pocket because you could get a denial. Maybe they're not covering that new technology, or they call it experimental, and it could trigger a wider range audit. So if your physician does this, remind him or her billing for services that you know are not covered by the insurance plan does not mean that the patient will be absolved from financial share of cost. You can only bill for medically necessary services, so if the insurance won't pay for the Medicare add-on code, they may not believe it's medically appropriate for that patient population. So keep that in mind. Then the next question, number 2, Terry, are the codes 99401 to 99404 and 99411 and 99412 billable? Group and individual preventative medicine counseling. So a rep told one of our physicians these are billable for weight loss counseling. I don't see the codes in the fee schedule. So no, these are not paid under the Medicare fee schedule, and the only service Medicare will pay for with an obesity diagnosis is GO447, which is an obesity screening, and counseling, and there's some strict frequency guidelines on that, so make sure you Google that. But also you have to check the plans because those are rarely billable, especially preventative individual and group service codes. So just because there's a code that exists in CPT doesn't make it payable. It just means that it's a description, so of something that could be done. Number 3, it shows that so now we're talking about the No Surprise Act. It shows that for a good faith estimate for uninsured and cash patients, that we only have to give it to patients that need to have information or an estimate of what they're going to have, but within 3 days in advance of their scheduled service. So we are finding that we're having problems because patients that are coming into the hospital through the ER don't want to pay for their bill when we balance bill them. And we don't have to give them 3 days business, notice in it, or 3 days. We have to give them a 3 days advance notice. We don't have to give them a GFE, right? Well, here's the thing when it comes to the No Surprise Act. The patient is at a facility that's out of network and your physician's all out of network, then the No Surprise Act doesn't apply to them because they know they went to a place that isn't something that'll be covered, and there shouldn't be an expectation of an in-network provider at an out-of-network facility. We have that happen here a lot of times with Kaiser, because if you're a Kaiser patient, you have to go, that's an HMO, you have to go to a Kaiser facility or it's not covered. And they're very clear for patients who have that insurance. But if it is a cash or no insurance patient, you may only be able to charge or bill them the amount that would be appropriate for one of your median payer reimbursements. So there is a rule that says they have to agree with what you're going to charge or bill them. But if they're emergent or incapacitated, then what I'm seeing is that you have to find that median amount, or you're going to have to go to an independent dispute resolution, an IDR, to figure that out. And it's a mess. So even though a GFE, good faith estimate, may not be necessary, you can't balance bill someone who went to an in-network facility and now there's an out-of-network doctor. So that's where you've got to kind of negotiate your prices. And hopefully, you don't have to do a GFE because it's that 3-day rule, but you have to be reasonable in what you bill the patient after the fact. The CodeCast podcast is also brought to you today by Vaseline Lip Therapy with aloe vera. Vaseline lip therapy tins are clinically proven to help heal dry lips. It's also not sticky or greasy, which means it goes on super easy. You can find Vaseline Lip Therapy on Amazon, Walmart, or at your local pharmacy. Number 4, the big question I had was whether it was, the big question that this person had for me, it says, can a nurse visit, so a nurse for 99211, under the physician supervision in the state of Florida, can this also be billed for a respiratory therapist, RT, or a certified clinical sleep health professional, CCSH? The physician is asking, I want to make sure that I can bill for their services. So first of all, I'm not sure what a registered respiratory therapist or a certified sleep health professional would need to do in an office. And they have to be some kind of a clinical medical necessary service. So are a few codes under direct supervision of a physician that a respiratory, therapist can do, but I don't see anything that says a nurse visit, because what would they do in the office that's away from procedural assistance for that respiratory patient? Same for the sleep tech. They are there to assist in the sleep lab, the nurse practitioner or PA, and there's nothing that would make sense for them to speak to the patient independently in an office setting and report a 99211 under the physician incident 2 rule. And again, is it part of a sleep study in the sleep area? So I've had the same question from primary care doctors on registered dietitians and nutritionists, and I explained to them, no, nurse visits, no, medical nutritional therapy, maybe, but then you're tied to either a diabetes or chronic kidney disease diagnosis, and no nurse visit. So they didn't listen, and 3 years later, Medicare and United Healthcare took back $3.2 million. So make sure you understand that you can't just throw nurse visit out there for any, and I'm air quoting, clinician that has some kind of a certification. First of all, their services may be limited to specific procedural services that you may find in the CPT book, or they may be specific to ICD-10 codes that, again, are for their specific services. But nurse visits wouldn't make sense for that type of provider. Number 5, patient is in the hospital as an inpatient. Our physician gets a request to do a cardiac consultation. Does he get to bill 99221 to 99223? We're being told by a BS payer, Blue Shield payer, only the admitting physician gets that code, but those admitting physicians are not part of our group. Okay, so here's where there's kind of a gray area, but if they're not part of your group and hopefully a different specialty, then the admitting physician is supposed to put still the AI modifier for admit inpatient on the end of an initial hospital visit, initial hospital or observation care service, which is the 99221 to 223. And then your provider, if you're called in to consult and a specialty consult, and again, they're not part of your group, different specialty, you should be able to bill the same without the modifier. Now, there is a caveat, and this is in CPT, under these services. If, let's say that the patient was admitted by their primary care, you're being asked to come in to consult, And Blue Cross is saying, no, only the admitting physician. Well, if there was a time that you did a consult, I would say within 30 days, or did it in anticipation of that patient going to the hospital, CPT says, no, now you're subject to the subsequent hospital. They're basically saying you can't get the full value of the admit because you already got it in your office consult. So a lot kind of to unpack there, but you should get it if it's two separate practices, two different diagnoses, two different specialties. But if it's related at all and there was an anticipatory visit outpatient prior to the patient being admitted, then you're now subject to the subsequent hospital codes. Number 6, we have a case where one of our payers has denied something called, okay, let me make sure I'm pronouncing this right, trephination, and that basically this was done during a 29888 and a 29866 code. So basically knee procedures in the office setting, ACL, and they also did 29881. They did a medial meniscectomy. But what that really is that's burring a hole for prep for a procedure. So in my opinion, that's included in major procedures, not extra. I know the practice asked if they can bill a unlisted code, but it's not a separate procedure that treats another area or body part independent of the major procedure. So I don't believe that an unlisted code for prep is appropriate. Number 7, Terry, I have a couple of questions. The provider starts an infusion at the urgent care center and sends the patient to the ER with the infusion still going. How can I bill for that? Okay, can I bill a split or shared visit in the ER? If more than 2 providers see the patient during the course of the treatment, can I do a split or shared visit? Who gets to bill? Is it a substantive portion? Would all of them have documentation? I'm confused. Okay, so this is a lot to unpack on this one. So if there is an infusion that is started in the urgent care, and it came from, let's say, an initial office visit from a patient that it wasn't a scheduled infusion, so it was either a new established patient where they came in and because of that exam, you figured out that encounter that they needed to have some kind of an infusion. Then the urgent care, first of all, is going to get an office visit. Okay, so they're going to get a clinic visit. Then if they start the infusion, they're going to get the medicine for the infusion. But if the infusion then carries to the patient to the ER, I'm thinking that the ER is going to get the infusion code since it has to continue in that setting and also make sure that once it's done, they have to then, change it out or take out that IV out of the patient. Now, if both were in the ER and there was 2 different providers, you might get 2 office visits with a 25 modifier. I know the CPT says you can get 1 in the office and 1 in the ER, but Medicare says no. They said 1, you get 1 per day. But here's the thing that you have to be careful. Monitoring ongoing infusion that started in the urgent care and then just ended in the ER isn't a reason for a second E&M. Monitoring, you're basically just transporting. You can't get paid to transport. And the urgent care, again, may get the evaluation and decision to infuse, but then the ER would get the infusion unless something else happened to the patient where there was a complication or something that they needed to assess. Remember, E&M services start with problems addressed. They're not addressing any problem in the ER. They're basically just, handing off the patient, probably just to monitor because it's a little safer in the hospital. Number 8, hi Terry, I'd like to check with you from an auditing perspective about nurse practitioner documentation. Our nurse practitioner saw the patient in the clinic and the MD wants to review the progress note. If the MD signs the progress note, which is the proper billing for the service, we claim the bill under the NP with the supervising MD or claim the bill under the NP only. Okay, so, and it says additional question or clarification, should we remind our doctors not to sign the progress note so we can bill the service under the NP only? Okay, I think there's a misunderstanding of how incident 2 and signing notes and everything works. First of all, you need to know what your state says. Okay, so for example, I'm in California, and our state says that physicians have to sign off on the documentation if they're billing as the supervising provider for that patient, all of them. So they have to go through after the end of the day and sign off on charts. But remember, you can only bill out under the physician if they initiated care with that patient with a treatment plan, and now the nurse practitioner on this follow-up visit is now seeing that patient and doing what that plan of care stated. So incident 2 means you're just carrying out the plan of care from the initial visit or the initial contact with the supervising provider. Not that you're signing off on it. Signing off on it is usually a requirement in most states. So that's kind of the secondary part of compliance. It has nothing to do with billing. The second thing is that if the patient came in for a new problem or anything was changed during that encounter, remember it has to be billed out under the NP no matter who signed off on it. And so that's something that you have to consider too, because it no longer qualifies for incident 2. So just reviewing the progress note, that's good medicine if the MD wants to do that, but to be able to bill for it under the physician, it's more than just signing off on it and reviewing the note. You have to make sure that not only were you the supervising physician, but you are the one that they're following your treatment plan. Or if you're the supervising physician in the office, they're following a treatment plan from the initial physician that saw them, and you're now saying, I'll be responsible for that treatment plan. So a lot of things there with Incident 2, and I know I haven't done that in a while on podcasts, but I think it's time to revisit the Incident 2 rules. So I will do that in an upcoming podcast. Number 9, Terry, our Medicare contractor pays our telehealth claims when using place of service 02 or 10 without the modifier 95 anymore. But do we still need to append it? Well, CPT has an Appendix P and Appendix T. Appendix P is for audio and video services, and Appendix T as in Terry, for audio only. And it means that there's codes in either of these appendices that are typically not done via telehealth, but they're put in there saying that they're likely appropriate for telehealth under the certain circumstances. So office visits are under the Appendix P, and to me, it would be appropriate to put the 95 modifier. So, even though it's not a Medicare rule anymore, it is a claims billing rule. So from American Medical Association. Number 10, I have a question that I can't find the answer to. Okay. In a behavioral health appointment with an adolescent patient, does the parent involvement in that visit count towards bumping up the charge from a level 3 to a level 4? So remember, there are 3 elements to an E&M service. There's number and complexity of problems addressed, then there's the data points, and then there's the risk of complications and our morbidity and mortality. Where does parent involvement come into that? Well, is an independent historian under Category 2 under a 99213 or 203, or it's under Category 1 under moderate, but it's only 1 out of 3 elements. And so it's not something that is going to bump up your code at all. It might support a higher level if there's other things going on, but the parent should be involved in an adolescent patient, and it does not add to the risk. It actually helps to have that there. Have the parent there so that there is an ongoing communication with the provider and the patient and the parent. So you're not adding risk, which remember, the reason that we bump up our codes is because the added risk of complications and or morbidity or mortality of the patient management, and having the parent involvement doesn't add risk, it actually lowers it and can help because of the understanding. You're not going to talk to a 3-year-old patient and hopefully they remember what you say. You're going to talk to the parent, hopefully with the patient there, and they're going to have that discussion all as a family or together as far as what's going to happen with that patient. So keep in mind, be careful with those kinds of misunderstanding insights, because I just wouldn't want you to get in trouble with that. It's I know it's complex, but it's also something that I know happens quite a bit. So on a personal note, I had a couple of you contact me and just say, hey, thanks for some of the shout outs on what shows you're watching or what you're streaming, and what are your suggestions. So again, some of the things, just in case you didn't hear it before, I love Suits. Oh my gosh, I'm kind of obsessed with that show. It's got 8 seasons on Netflix and 1 on Prime. So take a look at that. I love it. Also, I revisited a show that I didn't even know existed. I don't know where I was, but it's called Numbers, and it's with Rob Morrow, and it's just such a smart, great show. It's got 6 seasons, so take a look at that. That's just really an awesome show. And my husband and I are going to start a new show. It's called The Bosch Legacy, The Bosch Legacy, BOSCH, on Amazon. And it's from one of the Michael Crichton books that we're reading. So anyway, just take a look at some of those. I know right now I'm kind of over regular TV, and, we watch sports and then we stream stuff. So anyway, hopefully you find that helpful, and I'll give you some more, recommendations as you ask for them. So everyone, make it a great rest of your May, a great day, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.